morning, and thank you everybody for joining us on a new episode of ULR TV. My name is Álvaro Gómez. I'm a postdoctoral researcher at the Karolinska Institute in Stockholm. And today we're going to be discussing one of those new hot topics that everybody's talking about. We're going to be discussing the bispecific T-cell engagers, or BiTEs. And for this, I'm pleased to have as an interviewee Associate Professor Wolfgang Merkt, who is a researcher and consultant rheumatologist affiliated with Heidelberg University. So thank you, Dr. Merkt, for taking your time and coming here with us.
Thank you very much for having invited me.
So let's start with the very basics. So even though these therapies are very emerging and give hope for people with RMDs, and still many healthcare professionals and patients may not be aware of what BiTEs are. So let's start with the basics. So what are BiTEs essentially, and how are they administered to patients?
So BiTEs are a new format of antibodies that can be applied for therapeutic purposes. But in the first place, BiTEs is a term. It stands for bispecific T-cell engagers. So that means that these are antibodies that bind on the one hand side to the T-cells, which is why you call it T-cell engager. And on the other side, it can bind to any other antigen. For example, and this is how we use it in rheumatology, they can bind to antigens on B cells. Mm-hmm. For example, CD19 or CD20, or also on plasma cells, which would be BCMA as a target.
And how are those treatments given to patients? Is it like any other monospecific biologic?
So this is a group of antibodies. So there are different ways depending on the exact agent. There are three currently being tried in rheumatologic diseases. Teclistamab and blinatumomab have been those that have been applied most frequently in the last 2 years. So teclistamab is a BCMA targeting antibody, which kills both plasma cells and B cells, and this is given as a subcutaneous application, and you have to apply a step-up dosing protocol where you give it on day 1, 3, and 5. And day 5 is then the highest dose, and then you can repeat it or not. But this is not really established. So this is how it has been done in the past experimental treatments. And blinatumomab, on the contrary, is a very small molecule. It's not a complete IgG-containing antibody. It's just containing the antigen binding domains, which are linked by a small peptide, if you want. So it's cleared rapidly via the kidneys, and that implies that you give it as a continuous intravenous therapy. So you get an infusion over 24 hours per day over a couple of days. So it's completely different depending on the agent.
Okay, yeah, that's very insightful. So now if we step back a bit, so the landscape in rheumatology has been largely shaped by monospecific biologics and BiTE inhibitors. So how close do you think BiTEs are for becoming a realistic option in treating patients with RMDs?
I think drugs becomes realistic when there are clinical trials financed by the pharma industry, and there are a lot of trials popping up at the moment. So I think it's very realistic because we have the trials which are hopefully coming soon. Yeah, and that makes the drug being feasible, I guess. And your question also implies somehow how realistic I think that they are effective, and I think they are really effective, and they will be a treatment option in the future. I'm pretty sure.
Yeah, that's true. And even though we're still waiting for results from phase 3 trials, there's lots of evidence popping up very rapidly, as you mentioned. So can you summarize for us, what have we learned so far about the efficacy and safety of these therapies?
Efficacy and safety, again, depends on the exact bispecific T-cell engager we talk about. It has emerged, and that is also known from the oncological trials. So those drugs are copied for our diseases from hematology in most cases. So we already know the safety profile from cancer patients. That could be a little bit different in our autoimmune patients, of course. So we have to be aware of new side effects, and it could also be that side effects that occur in the cancer patients would maybe not occur in the rheumatological patients. But there are some peculiarities that we really carefully evaluate. For example, in the case of teclistamab, the BCMA targeting BiTE, we really have to monitor IgG levels in the blood because it's known that it basically induces in almost every patient a severe hypogammaglobulinemia, and that leads to a severe infection risk. And so it's necessary to replace IgGs at least once a level of 4 gram per liters is passed. So that's important for safety, and this has to be done over months. So this is certainly something that limits the use of teclistamab. And for blinatumomab, for example, the effects might be dose dependent. You might see hypoglobulinemia, but it's not that frequent. In general, being antibodies, we do not expect too many side effects regarding the livers or the kidneys, but rather infectious diseases, which also have popped up as a potential concern in those trials.
Okay, understand. So then we need to keep an eye on the upcoming data to then detect those signals that are still early days.
So far only a few patients have been treated, so we need to wait for the larger clinical trials.
And then if we step back a bit and think implementation now, so if we think, for instance, about CAR-based therapies, there have been certain difficulties in some parts of the world where both cost and infrastructure limit their applicability. So how do you envision the landscape for BiTEs? So being slightly easier to give than CAR-based therapies. So do you think it's going to be more accessible to patients worldwide?
Thank you for the question. I think this is really important, not just in this field, but in medicine in general. We have many different developments regarding new therapeutic options, not only in rheumatology, but also in other diseases, gene therapies and so on. So also cancer therapy is increasingly being expensive. So accessibility is really important. And that is not only the case in low-income countries, but also in high-income countries. So the question, can it be financed, is there everywhere. But coming back to CAR T cells, I have heard that they will be much cheaper in the future. The more CAR T cells are being produced, the more streamlined you can design the construction pathways and so on. So there is hope that it's getting cheaper, like with every other drug as well. But still, I think that is what you want to hear. BiTEs are way cheaper than CAR T cells. But you might also find monospecific antibodies that are really expensive. So there is no general rule, but what we know from the prices from oncology, teclistamab, mosunetuzumab, blinatumomab, are at the moment much cheaper than CAR T cells. So accessibility from this side is much better. But there is another barrier, especially to CAR T cells, which is the production process. And of course, this is also much easier regarding BiTEs.
Well, thank you so much for this very insightful talk. We understand that more and more information and data are coming. So hopefully in EULAR 27 and in future editions, we're going to learn more about these therapies. And thank you also for joining us online, and I hope you keep enjoying the conference.